Welcome to the deep dive. Today we're setting out on a mission, really, to master a topic that's absolutely critical in medicine: hypolipidaemic drugs.
Yeah, the ones that lower lipids.
Exactly. And this isn't just, a quick overview of which pill does what. Think of this as a masterclass. We want you, the dedicated learner, to walk away with an elite understanding.
We're talking deep physiology, the nitty-gritty pharmacology, and the actual strategies doctors use, driven by guidelines, to fight back against accelerated atherosclerosis.
It's about getting that expert-level grasp, isn't it?
It really is. And look, to truly understand these drugs, how they work, we first have to understand the system they're targeting. The enemy, so to speak.
Which is lipid transport itself.
Precisely. We need to get into the weeds of how lipids move around the body before we can talk about manipulating that system. We're going way beyond just definitions here.
Okay, so let's start right there. The foundation. Lipids, things like triglycerides, TGs, and cholesterol esters, CHEs, they hate water, right? They're hydrophobic.
Absolutely. Oil and water don't mix.
But they have to travel through blood plasma, which is mostly water. So how on earth do they manage that?
That's where lipoproteins come in. Think of them as sophisticated little transport pods.
Like microscopic delivery trucks.
Kind of, yeah. They have a core stuffed with the hydrophobic cargo, the TGs and CHEs, and then that core is wrapped in an outer layer that is water-friendly.
What's in that outer layer?
It's polar stuff, phospholipids, some free cholesterol, and really importantly, specific proteins called apoproteins. These act like address labels or identification tags.
Got it. So the lipoprotein structure basically hides the fatty stuff inside.
Exactly. It lets them navigate the bloodstream. And the type and number of these lipoproteins floating around determine your overall plasma lipid levels.
Okay, our sources mention 6 main classes of these lipoproteins. They're grouped by things like size, density, how much TG versus CHE they carry, and their job, their function.
Right, let's walk through them. We can start with the biggest and fluffiest, if you like.
Sounds good.
Okay, first up are chylomicrons, or chi, and what's left after they do their job, the chylomicron remnants, or chi-rem.
Where do these come from?
Directly from your diet. Think of them as the trucks carrying the fat and cholesterol you just absorbed from, say, lunch. They're packed mostly with triglycerides.
So they form in the gut, right? And head into the lymph?
That's right, via the lacteals, then into the blood. The liver eventually cleans up the remnants.
Okay, so dietary fats are handled by chylomicrons. What about fats the body makes itself?
That's where VLDL comes in, very low-density lipoprotein. The liver makes VLDL to ship out the triglycerides it synthesizes.
So tri for dietary TGs, VLDL for endogenous liver-made TGs. Makes sense.
Then, as VLDL travels around and unloads some of its TG cargo, it transforms. It becomes IDL, or intermediate density lipoprotein.
Intermediate, so it's a transitional state.
Exactly. It's smaller, denser, has relatively more cholesterol ester than TG compared to VLDL, and crucially, IDL is the direct precursor for the most famous, or infamous, lipoprotein.
LDL, low-density lipoprotein.
That's the one. ODL comes from IDL, and its main job, delivering cholesterol out to the body's tissues.
Which cells need cholesterol for membranes, hormones?
Right, essential stuff. But because it's the main deliverer of cholesterol to the periphery, high levels are strongly linked to atherosclerosis. It's the primary target we try to lower.
Okay, that leaves one more class.
The smallest, densest, and generally considered the good one, HDL, high-density lipoprotein.
Where does HDL come from?
It starts collecting cholesterol from tissues, from cell membranes, breaking down. Its function is basically the opposite of LDL.
So reverse cholesterol transport, taking it away from the tissues.
Exactly. It mocks up excess cholesterol and carries it back to the liver for disposal. That's why it's seen as protective.
Okay, we've got the players. Chylomicrons, VLDL, IDL, LDL, HDL, and the remnants. Now, how do they all interact? Let's trace that full cycle. This is where it clicks, right?
This is definitely the aha moment. Let's start with that meal you ate, the dietary pathway. Fats get broken down with bile acids, absorbed by the intestine.
And packaged into those big chylomicrons.
Right. They enter the lymph, then the blood. Now, floating in the blood isn't enough. They need to unload the triglycerides.
And that's where the enzyme lipoprotein lipase, LPL, comes in, attached to blood vessel walls.
Precisely. LPL acts like a gatekeeper. It reaches into the chylomicron, grabs triglycerides, and breaks them down into free fatty acids.
Which then gets soaked up by nearby tissues like muscle or fat cells.
Immediately. So the chylomicron shrinks, loses its TG cargo and becomes cholesterol-richer, the chylomicron remnant.
And the liver snatches those remnants up quickly, using receptors?
Very efficiently, yes.
Mm.
It recognizes those apoprotein tags on the surface and pulls them out of circulation. Dietary pathway done.
Now, the endogenous pathway. The liver's making its own TGs.
Packages them into VLDL, secretes it, and guess what? VLDL meets the same LPL enzyme.
So LPL chops up the TGs in VLDL too.
Yep, same process. VLDL sheds triglycerides, shrinks, gets denser, and becomes IDL.
Okay, and IDL is at that fork in the road.
Right. About half of the IDL gets taken up directly by the liver using the LDL receptor. The other half keeps luting TGs, becoming even richer in cholesterol esters until, boom, it's mature LDL.
Pure cholesterol delivery vehicle, heading for peripheral cells.
That's its job. But cells can get overloaded, right? Or just naturally turn over membranes, releasing cholesterol. How does the body manage that excess, that reverse trip?
This must be where HDL and its protective role really shine.
Absolutely. And it involves another key enzyme. When HDL picks up free cholesterol from a cell, well, free cholesterol is kind of slippery, mobile.
Needs to be locked down.
Exactly. The enzyme LCAT lecithin, cholesterol acetyltransferase, does that job. It's associated with the HDL particle.
What does LCAT do specifically?
It takes that free cholesterol HDL just picked up and esterifies it, basically attaches a fatty acid, turning it into a cholesterol ester.
And that traps it inside the HDL core.
Yes. And this is clever because by converting free cholesterol to esterified cholesterol, LCAT keeps the concentration of free cholesterol on the HDL surface low.
Ah, maintaining a gradient. So cells wanting to offload cholesterol always see HDL as empty for free cholesterol.
Precisely. It drives the continuous removal of cholesterol from the periphery. Then, that esterified cholesterol inside HDL can get transferred over to VLDL or IDL particles.
Which eventually head back to liver anyway, completing the cycle.
A beautiful dynamic system when it works.
But when it breaks down, when there's just too much lipid cargo.
That's the danger zone. That's atherogenesis. If you have chronically high levels of these lipoproteins, especially the cholesterol-rich ones like LDL, IDL, even VLDL, the system gets overwhelmed.
The body's cleanup crew, the macrophages, can't keep up.
They try. They start engulfing these excess lipoproteins. But if they take in too much cholesterol, they can't process it all. They become these bloated, dysfunctional cells called foam cells.
And those foam cells are the start of trouble in the arteries.
They are the core component of atheromas, those fatty plaques that build up in artery walls, that build up the inflammation it causes. That's atherosclerosis. That's what leads to heart attacks and strokes.
We can sometimes even see the buildup elsewhere, right? Like xanthomas.
Yes. In severe cases, that excess cholesterol deposition shows up as yellowish lumps called xanthomas in skin or tendons. It's a visible sign of extreme lipid overload.
So, to recap the culprits, high VLDL, high IDL, high LDL are all considered atherogenic. High chylomicrons are less common, but still bad.
And HDL remains the good guy, facilitating that LCAT-driven cholesterol removal.
Okay, understanding the physiology helps us figure out why someone might have high lipids or hyperlipoproteinemia. Broadly, the causes fall into two buckets, right? Secondary and primary.
That's the standard approach, and it's crucial to check for secondary causes first. These are high lipids caused by something else.
Like what sort of things?
Common culprits include poorly controlled diabetes, thyroid problems like myxoedema, chronic heavy alcohol use, kidney issues like nephrotic syndrome.
And importantly, certain medications. We need to look out for those too.
Absolutely. Corticosteroids are notorious. Some oral contraceptives, certain beta blockers, these can all mess with lipid levels. The key is, if you fix the underlying problem or stop the offending drug, the lipids might just normalize on their own.
Always look for the reversible cause first. Makes sense. What if it's not secondary?
Then we're looking at primary hyperlipoproteinaemias. These are rooted in genetics. Sometimes it's a single faulty gene causing a major problem that's monogenic.
Often severe inherited conditions.
Right. Or it can be polygenic or multifactorial, a mix of multiple subtle genetic variations interacting with diet, exercise, lifestyle factors.
This is where knowing the specific types, often linked to specific genetic defects, becomes really important for understanding the mechanism. Our sources break these down, often using the Fredrickson classification.
Yes, let's synthesize those major primary types. Start with type I, also called familial lipoprotein lipase deficiency.
Okay, the name gives a clue. Problem with the LPL.
Exactly. It's a rare monogenic disorder where the LPL enzyme is basically absent or non-functional. Remember LPL's job?
Breaking down triglycerides in chylomicrons.
Right. So if LPL is missing, Those big TG-packed chylomicrons from your diet just pile up. They can't unload their cargo.
What does the lipid panel look like?
Astronomical triglycerides, TG way up, UPA, and elevated cholesterol too, CH, mostly because it's riding along in those chylomicrons. The big clinical risk here isn't usually atherosclerosis, it's acute pancreatitis from the super high TGs.
Okay, type I is LPL deficiency. What about type CA? Familial hypercholesterolemia.
This one is less rare and a major driver of early heart disease. It's also monogenic usually. The core defect here is in the LDL receptor.
The receptor on the liver that's supposed to clear LDL from the blood.
That's the one. Either there aren't enough receptors or they're structurally faulty, so the liver can't grab onto and remove LDL and its precursor IDL effectively.
Like a clogged drain for cholesterol?
A very good analogy. LDL just accumulates in the blood to very high levels, so cholesterol is way up. But because VLDL handling isn't the main issue, triglycerides are usually normal. These patients can have heart attacks in their 30s or 40s or even earlier.
That's serious. Okay, next, type 3. Dysphtalipoproteinemia. Sounds complex.
It's rarer, sometimes called remnant removal disease. Here, the problem isn't the receptor itself, or LPL, it's the particle being cleared, specifically an abnormal form of apoprotein E, ApoE, on the surface of IDL and chylomicron remnants.
APE is one of those address labels the liver receptors look for.
Exactly. If the ApoE label is wonky, the liver has trouble recognizing and clearing these remnant particles. So both IDL and chylomicron remnants build up.
What does that do to the lipids?
Since both remnants contain both cholesterol and TGs, you see elevations in both.
Yeah.
CHO.
Got it. And finally, type IV, hypertriglyceridemia.
This is the most common one we see, often multifactorial tied to genetics, but also strongly influenced by diet, obesity, insulin resistance. Sometimes it's monogenic too.
What's the key feature?
The liver is overproducing VLDL. Remember, VLDL is the main carrier for endogenous TGs.
So high VLDL means
very high triglycerides. Cholesterol levels might be normal or only slightly up because the primary cargo here is TG, not cholesterol. This pattern is very common in people with metabolic syndrome or type 2 diabetes.
Okay, we've got the physiology, the different ways they can go wrong. Now let's talk about fixing it. And the first drugs that come to mind are the statins. They're the cornerstone, right?
Absolutely. HMG-CoA reductase inhibitors, or statins. They're generally the most effective and, importantly, the best tolerated class for lowering LDL cholesterol.
How do they actually work? You mentioned a two-step process.
Right. Step 1 is hitting cholesterol production directly. Statins competitively inhibit a key enzyme called HMG-CoA reductase.
And that enzyme does what again?
It controls the rate-limiting step in the whole process of your body making cholesterol. Specifically, it converts a molecule called HMG-CoA into mevalonate. Block that step, and you block downstream cholesterol synthesis.
How much does it reduce synthesis?
At typical therapeutic doses, you're looking at a 20 to 50% reduction in the liver's cholesterol production, which is significant.
But you said that's only half the story. The body fights back.
It does. The liver is smart. When it senses its internal cholesterol levels dropping because of the statin, it activates a powerful compensatory mechanism.
Which is?
It dramatically increases the number of LDL receptors it puts on its surface.
Ah, the same receptors involved in familial hypercholesterolemia, but now the liver is making more of them.
Exactly. It's trying to scavenge more cholesterol from the blood to make up for the production deficit. These extra receptors act like vacuum cleaners, pulling IDL and, most importantly, LDL out of the circulation much more effectively.
So the main effect we see, lower LDL in the blood, is actually more due to increased clearance than decreased production.
That's generally believed to be the dominant effect, yes. The increased catabolism driven by receptor upregulation is key. It's a beautiful 1-2 punch.
What does this do to the overall lipid profile?
The primary effect, the headline, is LDL reduction, anywhere from 20% up to 55% with the potent ones.
That's a huge drop. What about TGs and HDL?
You get secondary benefits there, too. Triglycerides usually drop by 10 to 35%, partly because VLDL production might decrease a bit, too. And HDL, the good cholesterol, often sees a modest bump, maybe 5 to 15%.
You mentioned potent statins being better for TGs?
Yeah, the higher efficacy ones like atorvastatin and rosuvastatin can really knock down TGs quite well, maybe 25 to 35% reduction, even if they're only moderately elevated to begin with.
Okay, let's get into the elite details. Dosing time, does it matter when you take them?
It used to matter more. The thinking was that cholesterol synthesis peaks overnight, so HMG-CoA reductase activity is highest around midnight.
So short-acting statins needed to be taken at bedtime.
Right. But the longer-acting, more potent ones we use commonly now, atorvastatin has a half-life of like 14, 18 hours. Rosuvastatin, maybe 18, 24 hours. They stick around long enough that the timing doesn't really matter. They provide 24-hour inhibition.
Good to know. What about how they're broken down? Metabolism is always key for drug interactions.
Hugely important here. Most statins, in fact, all of them except for rosuvastatin and pravastatin to some extent, are primarily metabolized by the liver enzyme system, CYP3A4.
Ah, CYP3A4. That's involved in metabolizing tons of other drugs,
A
right?
huge number, which means if a patient is taking another drug that strongly inhibits CYP3A4.
Like certain antibiotics or antifungals.
Exactly. Ketoconazole, erythromycin, even grapefruit juice is a moderate inhibitor, or drugs like cyclosporine. Taking those with a CYP3A4 metabolized statin can cause statin levels in the blood to shoot way up,
Increasing the risk of side effects, especially muscle problems.
dramatically increasing the risk. It's a critical interaction to watch for. Rosuvastatin, not using that pathway, avoids many of those issues.
Okay, comparing the different statins. Atorvastatin and rosuvastatin seem like the heavy hitters for lowering LDL.
They are. Both can achieve over 50% up to 55% LDL reduction at their max doses. Rosuvastatin is generally considered the most potent on a milligram for milligram basis.
What about simvastatin? It used to be very common.
Still is, but there's a specific warning about the highest dose, 80 milligrams. The data showed a significantly higher risk of myopathy, muscle damage, with that dose compared to others or lower doses.
So guidelines now restrict its use.
Yes. NICE in the UK, ACA in the US. They basically say only use simvastatin 80 milligram if the patient has been on it long-term without issues, or if the potential benefit really outweighs that known increased risk. For new starts, you'd usually pick atorva or rosuva if you need high intensity.
And pitavastatin, that's newer.
It is. Very potent dose for dose, but its maximum approved dose is only 4 milligrams, which kind of caps its total efficacy at around 40% LDL reduction. Still good, but not quite reaching the levels of high-dose atorva or rosuva. Also, important note, avoid combining pitavastatin with gemfibrozil.
We'll come back to gemfibrozil. It sounds problematic. So side effects. Generally well tolerated, you said?
Surprisingly well, yeah. In big trials, the rate of side effects is often similar to placebo. Most common things are mild, some GI upset, maybe headache, mild rashes.
But the muscle issues are the main concern.
That's the one everyone focuses on. Mild muscle aches or myalgia are relatively common, maybe reported by up to 10% of people, usually manageable.
But it can get serious.
It can. You can see rises in muscle enzymes like CPK. Rarely, it progresses to true myopathy, which is significant muscle pain and weakness and high CPK. And even rarer, but potentially fatal, is rhabdomyolysis.
Where the muscle breaks down so severely, it releases components that damage the kidneys.
Exactly. Fatalities have occurred. It's rare, but it's why we take muscle symptoms seriously.
And the risk goes up with certain combinations.
Massively. Combining a statin, especially a CYP3A4 metabolized one, with nicotinic acid, or particularly the fibrate gemfibrozil, significantly increases the risk of both myopathy and liver injury.
Okay, let's nail down this gemfibrozil interaction. Why is it so bad with statins? You mentioned OATP2 earlier with pitavastatin.
Yes, this is a critical piece of elite knowledge. Gemfibrozil does something quite specific. It inhibits a transporter protein in the liver called OATP1B1, often referred to historically or in some texts as OATP2. This transporter is responsible for pulling statins out of the bloodstream into the liver cells where they can be metabolized.
So gemfibrozil blocks the statin from even getting into the liver properly.
Effectively, yes. By inhibiting OATP1B1 uptake, gemfibrozil causes the statin levels circulating in the blood to become much higher and stay high for longer.
Bypassing the normal clearance route and leading to toxic systemic levels?
Precisely. That's why the combination is generally considered contraindicated or requires extreme caution. A normally safe statin dose can become dangerous.
If you need to combine a statin with a fibrate, what's the preferred option?
Fenofibrate. The data suggests fenofibrate interferes much less with statin metabolism and, crucially, with that OATP1B1 uptake pathway. So the risk of severe myopathy is significantly lower compared to gemfibrozil. It's the go-to fibrate for combination therapy if absolutely necessary.
Good distinction. Any other notable risks with statins?
Well, there's been discussion about a small increase in the risk of developing type 2 diabetes, maybe around a 10% relative increase noted in large studies. The absolute risk is small, and the cardiovascular benefits generally far outweigh this risk, but it's something to be aware of.
And pregnancy.
Absolutely contraindicated. Statins should not be used during pregnancy due to potential risks to the fetus.
Okay, beyond just lowering lipids, statins seem to have these broader cardiovascular benefits, reducing heart attacks, strokes. What's going on there?
This is maybe the most exciting part. The benefits often seem larger than you'd expect just from the LDL reduction alone. We think statins have direct anti-atherosclerotic effects.
Like what?
Several things. They seem to improve the flexibility or compliance of coronary arteries. More importantly, they appear to stabilize existing plaques.
How do they stabilize plaque? That sounds crucial.
It is. Most heart attacks happen when a plaque ruptures. Plaque rupture is often driven by inflammation within the plaque, largely mediated by macrophages. Statins seem to suppress that macrophage activity and inflammation.
So they cool down the hot plaques.
Kind of, yeah. They help to strengthen the plaque's fibrous cap, making it thicker and less prone to breaking open and causing a clot.
That's huge. Anything else?
They also improve the function of the endothelium, the inner lining of blood vessels. They can increase the production of nitric oxide, or NO, which helps vessels relax. And they may reduce the oxidation of LDL particles, making the LDL itself less damaging to the artery wall.
So multiple vascular benefits beyond just the numbers.
Definitely. There's even newer evidence suggesting they might reduce the risk of venous thromboembolism, blood clots in veins, like after knee or hip replacement. It points to broad vascular protective effects.
All right, statins are clearly the foundation. But what else is in the toolkit? Let's talk about the other classes, maybe starting with the older ones. The bile acid sequestrants, or resins. Cholestyramine, cholesterol.
Yeah.
There's a newer one, too, cholecevlin.
Right, the resins. Their mechanism is quite different. They're basically large, inert polymers that you take orally, but they don't get absorbed into the body.
They stay in the gut.
Entirely. They work by binding onto bile acids in the intestine. Bile acids are made by the liver from cholesterol and are essential for fat digestion.
And normally the body recycles most of them, right? The enterohepatic circulation.
Exactly. About 95% are reabsorbed. But these resins grab onto the bile acids and prevent their reabsorption. So you end up excreting more bile acids and the cholesterol they contain in your feces.
So the liver loses its recycled bile acids?
Yeah.
How does it respond?
It has to make more. And to make more bile acids, it needs cholesterol. So it starts converting more of its internal cholesterol stores into bile acids.
Depleting its own cholesterol pool. Hang on, this sounds familiar.
It should. Just like with statins, when the liver senses low intracellular cholesterol, it responds by
upregulating LBL receptors.
bingo. It puts out more LDL receptors to grab more cholesterol in the form of LBL and IDL from the blood. So the net effect is increased clearance of LDL.
What's the impact on lipids?
It's modest for LDL, maybe a 15 to 25% reduction. HDL might go up slightly, 3 to 5%. But triglycerides, they're usually not affected and sometimes can even increase a bit.
Why aren't they used more often if they lower LDL?
The big limitation is patient acceptability. They're just not pleasant to take. They often come as powders you mix with liquid, can taste gritty or unpleasant.
And the doses are large.
Often quite large, yes. Plus, they cause a lot of gastrointestinal side effects. Constipation, bloating, gas are very common. And because they're binding agents in the gut, they can interfere with the absorption of many other medications. You have to time doses carefully.
So, mainly for people who absolutely can't take statins, or maybe as an add-on in specific cases.
Pretty much. Cholestyramine is sometimes considered slightly better tolerated, but overall compliance is a major issue.
Okay, let's shift gears to the fibrates, gemfibrozil, which we flagged, fenofibrate, bezafibrate, these triglycerides more, right?
Yes, fibrates are primarily triglyceride-lowering drugs. Their mechanism is completely different. It involves activating a nuclear receptor called PPAR-alpha.
PPAR-alpha. What does activating that receptor do?
PPAR-alpha is found in the liver, fat tissue, muscle. When a fibrate binds to it and activates it, it switches on genes involved in fat metabolism. A key effect is boosting the synthesis and activity of lipoprotein lipase, LPL.
The enzyme that breaks down TGs and VLDL in chylomicrons.
The very same. More LPL activity means faster clearance of triglyceride-rich lipoproteins like VLDL. PPAR-alpha activation also increases fatty acid oxidation, burning fat for energy, and can decrease the liver's own production of triglycerides.
So multiple hits against TGs. What's the typical effect on the lipid panel?
The primary effect is a significant drop in triglycerides, often 20 to 50%. They also tend to raise HDL, maybe 10 to 20%, which is a nice bonus.
What about LDL?
LDL effects are more variable, usually a modest decrease, maybe 5 to 15%. But remember that warning about gemfibrozil in people with very high triglycerides. Gemfibrozil can sometimes paradoxically increase LDL levels as the large VLDL particles are broken down into smaller LDL-like particles.
Okay, so when are fibrates the go-to choice?
They're considered first-line therapy when triglycerides are the main problem, like in type 3, 4, or V hyperlipoproteinemia. Especially when TGs are extremely high, say over 500 milli-GDL, the immediate goal is preventing acute pancreatitis, and fibrates are key for that.
Any trial data supporting their use for cardiovascular events?
Yes, particularly in patients with that high TG, low HDL profile. The Helsinki Heart Study, for example, showed gemfibrozil reduced heart attacks in men with that pattern. Other studies with bezafibrate showed similar benefits in specific patient groups.
And if you must combine with a statin, fenofibrate is preferred.
Yes, for the reasons we discussed, less impact on statin metabolism via OATP1B1, lower myopathy risk. Fenofibrate also tends to have a slightly better effect on raising HDL and lowering LDL compared to gemfibrozil.
All right. Next up, nicotinic acid, or niacin. This isn't the same as the B vitamin dose, right?
No, not at all. We're talking pharmacological doses, grams per day, which have lipid-lowering effects completely unrelated to its vitamin function.
What's its big claim to fame?
Niacin is the single most effective drug we have for raising HDL cholesterol. It can boost HDL by 20 to 35%, which is quite dramatic. It also lowers TGs effectively, 20-50%, and LDL modestly, 15 to 25%. Plus, it's one of the few things that significantly lowers LPA, another atherogenic particle.
Sounds impressive. How does it work?
It's complex, but a key action is inhibiting lipolysis, the breakdown of fat inside fat cells, adipocytes.
How does it stop fat breakdown?
It binds to a specific receptor on the surface of fat cells called the niacin receptor, GPR109A. This is a G protein-coupled receptor. Binding to it reduces intracellular cyclic AMP levels.
Less CAN-MP means less activation of the enzymes that break down stored triglycerides.
Exactly. It dampens down hormone-stimulated lipolysis. The result is fewer free fatty acids, FFAs, get released from fat tissue into the bloodstream.
And if fewer FFAs travel to the liver?
The liver has less raw material to make triglycerides and package them into VLDL. So VLDL production drops, leading to lower TGs and subsequently lower LDL.
Okay, potent effects, but I sense a but coming.
A big but: tolerance. Niacin is notoriously poorly tolerated. Maybe only half the patients prescribed it can actually stick with the full dose long term.
Why? What are the side effects?
The most immediate and common one is intense flushing.
Like turning bright red?
Yes, often with feelings of heat and itching. It's caused by the release of prostaglandin D2, PGD2, in the skin, which causes blood vessels to dilate dramatically. It's harmless, but very uncomfortable.
Did you do anything about the flushing?
Yes, you can mitigate it. Starting with a very low dose and increasing gradually helps. Taking it with food, using extended release formulations, and taking low-dose aspirin about 30 minutes beforehand helps a lot, because aspirin blocks prostaglandin synthesis.
Is that why some niacin pills come combined with another drug, loropeprant?
Exactly. Loropeprant specifically blocks the receptor that PGD2 acts on, aiming to prevent the flush. Those combination products were developed to improve tolerance.
Are there more serious risks than flushing?
Oh, yes. The most important one is potential liver dysfunction or even jaundice, especially with older sustained-release forms. Regular liver function tests are essential. It can also worsen blood sugar control.
So probably not great for diabetics.
Generally avoided in diabetics, yes. It can also raise uric acid levels, potentially triggering gout, and there have been rare reports of atrial arrhythmias. So, significant downsides.
Okay, moving to a much newer mechanism, ezetimibe, a sterile absorption inhibitor.
Yes, ezetimibe was quite novel. It works entirely in the intestine, like the resins, but with a much more specific target.
What does it target?
It inhibits a specific protein called NPC1L1. This protein is a cholesterol transporter located right on the surface of intestinal cells, responsible for absorbing cholesterol from your diet and cholesterol secreted in bile.
So it blocks cholesterol from even getting into the body from the gut.
That's the idea. It reduces the absorption of both dietary cholesterol and biliary cholesterol that gets recycled.
What's its effect on LDL when used alone?
It's relatively modest on its own. You get maybe a 15 to 20% reduction in LDL, not nearly as potent as a statin.
Why isn't it stronger if it blocks absorption? Does the body compensate again?
It does. If you block cholesterol absorption, the liver senses less cholesterol coming back from the gut, its response. Ramp up its own internal cholesterol synthesis.
Ah, so blocking absorption triggers more production. That sounds like a perfect setup for combination therapy.
Exactly. Combine ezetimibe with a statin. The ezetimibe blocks absorption, the statin blocks the compensatory increase in synthesis. The two mechanisms work together synergistically.
What kind of LDL lowering can you get with a combo?
It's impressive. Adding ezetimibe to a statin typically gives an additional 15–25% LDL reduction on top of what the statin does alone. With potent statins, you can push total LDL reduction towards 60% or even more.
That sounds great pharmacologically. Has it translated to proven benefits and outcomes, like reducing heart attacks?
The data there has been a bit more nuanced. Used alone, ezetimibe hasn't clearly shown a reduction in cardiovascular events. However, the big Improve It trial looked at adding ezetimibe to simvastatin in patients who'd already had an acute coronary event.
What did Dimizivit find?
It found that the combination group, Simva plus ezetimibe, did have a small but statistically significant further reduction in cardiovascular events, about 2% absolute risk reduction compared to simvastatin alone.
So it confirmed that lowering LDL even further, even from already low levels using this absorption inhibition mechanism on top of the statin, does provide some additional clinical benefit.
That's the takeaway. It validated the lower is better concept, even using non-statin add-on therapy, although the benefit size was modest.
Okay, one last drug mentioned in our sources, seraglitazar. Sounds different. Dual agonist.
Yes, seraglitazar is interesting. It's chemically distinct from fibrates, or the TZD diabetes drugs, but it activates both PPAR-alpha and PPAR-gamma.
So it combines the triglyceride-lowering effects of PPAR-alpha activation, like fibrates,
with the insulin-sensitizing effects of PPAR-gamma activation, like thiazolidinediones, the TZDs used for diabetes.
Where is this used?
Currently, its approval seems limited. Mentioned as approved in India specifically for diabetic dyslipidemia, the common pattern of high TGs and low HDL in diabetics, particularly when it's not controlled by a statin alone.
What are the potential advantages of hitting both PPARs?
The hope is to tackle multiple aspects of metabolic syndrome simultaneously: lower triglycerides, lower blood sugar, both fasting glucose and HbA1c, potentially raise HDL without causing the common side effects of PPAR-gamma drugs like edema and weight gain.
And early results.
Small trials suggested it did lower TGs and glucose markers, and importantly, didn't seem to cause that edema or weight gain. But it's still relatively new in terms of large-scale, long-term data.
All right, we've covered the drugs, the mechanisms, the side effects. Now, how do we put it all together? How do clinicians decide who gets what drug and when? There's been a big shift in thinking, hasn't there?
A massive shift. Early on, we treated high numbers. But landmark trials like the Heart Protection Study, HPS, and ASCOT-LA really changed the game.
What do they show?
They demonstrated huge benefits: reduced deaths, heart attacks, strokes from lowering LDL cholesterol with statins, even in people who didn't have super high levels to begin with, but who are at high risk for other reasons.
So the focus shifted from just treating the number to treating the overall risk of having an event.
Precisely. This led to the idea of prophylactic statin use for high-risk individuals, even with average cholesterol. And now it's standard practice that anyone who's had an acute coronary event, like a heart attack, gets put on a statin, pretty much regardless of their starting lipid levels.
Because stabilizing plaque is key after an event.
Absolutely. Now, we still have target numbers in mind. The classic NCEP guidelines from 2001 provide good reference points for desirable levels.
Remind us of those.
Ideally, total cholesterol 200 mg/dL, LDL cholesterol, the main target, optimally 100 mg/dL, or even 70 mg/dL for very high-risk patients like those with established heart disease. HDL, the good stuff, 40 mg/dL for men, 50 mg/dL for women, and triglycerides, 150 mg/dL.
But treatment isn't just about hitting those numbers anymore. It's about risk reduction strategy. And it always starts with lifestyle, right?
Non-negotiable. Before any drug or alongside any drug, you absolutely need lifestyle modification. Intensive dietary changes, regular exercise, weight control if needed, quitting smoking, moderating alcohol. That's the foundation.
And often low-dose aspirin for prevention if they're high risk and don't have contraindications.
Yes, that's frequently part of the overall strategy.
Yeah.
Then, when drugs are needed, the current approach, heavily influenced by the 2013 ACHEA guidelines and similar NICE guidelines in the UK, focuses on statin intensity.
Intensity meaning how much LDL reduction you expect.
Exactly. Instead of chasing a specific LDL target number for everyone, the guidelines define categories of patients who benefit most from statins and recommend a certain intensity of statin therapy based on their risk profile.
What are the intensity levels?
There are basically two main ones we talk about: high intensity and moderate intensity,
High intensity means?
aiming for an LDL reduction of at least 50%. This requires the most potent drugs at robust doses, typically atorvastatin 40 or 80 milligrams or rosuvastatin 20 or 40 milligrams.
And moderate intensity?
That targets an LDL reduction of 30 to 50%, achieved with lower doses of atorvastatin 10-20 milligrams or rosuvastatin 5-10 milligrams, or standard doses of other statins like simvastatin 20-40 milligrams, pravastatin 40-80 milligrams.
And the guidelines tell us who should get which intensity.
Yes, the ACC-AFA guidelines identified 4 major statin benefit groups. If you fall into one of these groups, statin therapy is strongly recommended. This framework provides clear guidance.
Okay, let's walk through those 4 groups. Group 1.
Group 1 is individuals who already have clinical atherosclerotic cardiovascular disease, ASCVD, meaning they've had a heart attack, stroke, angina, peripheral artery disease. They have established disease.
What intensity do they get?
If they are 75 years old or younger, they automatically qualify for high-intensity statin therapy. The goal is aggressive secondary prevention, stabilizing those plaques.
Makes sense. Group 2.
Group 2 is individuals with very high LDL cholesterol, specifically LDL tine of 90-91 nil-GDL. This usually signifies a primary, often genetic hypercholesterolemia like FH.
Even if they haven't had an event yet?
Yes. Their lifetime risk is so high due to that extreme LDL level that they also warrant high-intensity statin therapy right off the bat.
Okay. Group 3.
Group 3 focuses on individuals with diabetes mellitus, aged 40 to 75 years.
Why specifically diabetics?
Because diabetes itself is a major risk factor for ASCVD, so diabetics in this age range automatically qualify for at least moderate-intensity statin therapy.
At least. Can they get high intensity?
Yes. If their calculated 10-year risk of having an ASCVD event is 7.5% or higher, they should be bumped up to high-intensity therapy.
Got it. And the last group, Group 4.
Group 4 covers everyone else, essentially. Non-diabetics, aged 40 to 75, who don't have established ASCVD, don't have LDL TQ 191, but whose calculated 10-year ASCVD risk is 7.5% or higher.
So primary prevention based on calculated risk.
Exactly. These individuals are deemed high enough risk to warrant starting moderate to high-intensity statin therapy to prevent that first event.
That's a very clear framework. But what about patients whose main issue isn't high LDL, but maybe very low HDL or very high triglycerides? How do the guidelines handle those?
That's where it gets more complex, and the evidence is still evolving. Let's take low HDL-CH first. We know niacin raises HDL the most, followed by fibrates.
So add one of those to a statin.
That was the hope. But several large, important recent trials like AIM-HIGH with niacin and HPS-2TH-RIVE with niacin laroparprin looked at adding these HDL-raising drugs to patients already well-treated with statins, meaning their LDL was already low.
And what did they find?
Disappointingly, they found that adding the HDL-raising drug did not provide any further reduction in cardiovascular events compared to the statin alone. And in some cases, it added side effects or risks.
So just because you make the HDL number go up doesn't mean you get better outcomes.
That seems to be the conclusion, at least when LDL is already well controlled by a statin. The current thinking is that for ASCVD prevention, the main focus should remain on intensive LDL lowering with statins. The benefit of specifically targeting HDL with additional drugs is uncertain and generally not recommended for routine prevention.
Okay, what about raised triglycerides? Say someone's on a statin, LDL is okay, but TGs are still high.
First step, always. Look for and address reversible causes: diet, alcohol, uncontrolled diabetes, medications. If TGs remain high despite statin therapy, the approach depends on how high.
Let's say moderately high, like 200 to 499 mg/dL.
In this range, the evidence for adding another specific TG-lowering drug, like a fibrate or niacin, for the purpose of preventing ASCVD events is considered uncertain or weak by current guidelines like NICE. Routine addition isn't generally encouraged. The focus remains optimizing the statin and lifestyle.
But what if the TGs are really high, like over 500 mg/dL?
That's different. Levels that high pose a significant immediate risk of acute pancreatitis. This is a serious, potentially life-threatening condition.
So the goal shifts from long-term ASCVD prevention to short-term pancreatitis prevention.
Exactly. In this scenario, adding a specific triglyceride-lowering drug, usually a fibrate, preferably fenofibrate for safety with the statin, or possibly nicotinic acid is indicated, specifically to get those TGs down quickly and reduce the pancreatitis risk. It's used in addition to the statin.
That makes sense. Priority is preventing the imminent danger.
Precisely.
Okay, to really cement this strategy, let's use the example from the source material problem-directed study 46.1, a real-world scenario.
Sounds good. We have a 50-year-old male executive. He's sedentary, doesn't smoke. His stats: BMI is 27, so he's overweight. Waist circumference is 38 inches. Blood pressure 130/86, pre-hypertensive.
Now the lipids: total cholesterol 268, HDL is low at 38, triglycerides are slightly elevated at 160, but the kicker, LDL cholesterol is 198 mg/dL.
Okay, let's analyze this using the framework. That LDL of 198, where does that put him?
LDL teeny orders, that puts him squarely into statin benefit group 2, primary hypercholesterolemia.
Correct. Even without calculating his 10-year risk score, which would likely be elevated anyway given his age, low HDL, BMI, waistline, that LDL alone qualifies him.
So what's the recommendation?
Group 2 mandates high-intensity statin therapy. No question, we need to bring that LDL down significantly.
So we'd start him on something like atorvastatin 40 or 80 milligram, or rosuvastatin 20 or 40 milligram.
Exactly. And what would our treatment target be?
Given his very high starting LDL and other risk factors, we'd want to be aggressive. Aim for an LDL well below 100 mg/dL, and ideally push toward getting it below 70 mg/dL if possible.
Perfect. That illustrates how the guidelines translate directly into clinical action.
This has been incredibly comprehensive. We've gone from the basic lipid carriers like chylomicrons and VLDL through the elegant reverse transport system involving HDL and LCCAP.
To the core mechanism of statins inhibiting HMG-CoA reductase, yes. But, crucially, that resulting upregulation of LDL receptors, that dual action is key.
We've also dug into the specific risks, like the OATP1B1 interaction making jogebrosil dangerous with statins, and why fenofibrate is the safer choice for combination.
And we've tackled the complexities of combination therapy, understanding why adding drugs just to raise HDL hasn't panned out in major trials when LDL is controlled, and when targeting very high TGs is essential for pancreatitis prevention versus uncertain for ASCVD prevention.
The bottom line seems to be, statins are king, not just for lowering numbers, but for those powerful plaque-stabilizing and anti-inflammatory effects.
They really are. The evidence for their benefit is overwhelming.
Which leads to that final provocative thought. If statins work so well partly by calming inflammation and stabilizing plaques, effects that go beyond just LDL math,
then what other pathways are involved in maintaining the health and integrity of that artery lining, the endothelium? What else contributes to durable plaque stability?
Right. If the ultimate goal isn't just managing numbers in the blood, but ensuring the physical structure of the artery wall remains stable and healthy long-term.
What other molecular targets, maybe completely outside the traditional lipid pathways we've discussed today, could we potentially leverage? How can we engineer long-lasting vascular health and plaque resilience?
That feels like the next frontier in cardiovascular medicine. A great place to leave our listeners thinking.